American Society's 2020 guidelines recommend initiating treatment for anyone with a T-score in the osteoporotic range or a T-score in the osteopenic range with a history of a fragility fracture or an elevated FRAX score, estimated by the FRAX calculation. The guidelines also emphasize the importance of lifestyle modifications, which include a daily dose of vitamin D of around 800 to 1,000 international units, as well as calcium intake of 1,200 milligrams daily. By following these guidelines, we can ultimately reduce risk of fractures and improve quality of life. In terms of choice of therapy, then the typical first-line agent is a bisphosphonate, either alendronate, risedronate, evandronate, or zoledronic acid. Zoledronic acid is an IV bisphosphonate, and it's a good choice for when adherence is an issue. Denosumab is also a good alternative for those who are intolerant of bisphosphonates or for those who have end-stage renal failure. For individuals that are very high risk, such as those with multiple fragility fractures or those with very low T-scores, then anabolic agents such as abaloparatide, teriparatide, or romosozumab should be considered. Calcitonin and selective estrogen receptor modulators are not used first line and are only considered in selective patients. Due to concerns for renal toxicity, bisphosphonates should only be used in individuals with GFRs higher than 35 milliliters per minute. Regarding duration of treatment, a DEXA scan should be done every 1 to 2 years while on therapy to assess response to therapy and as well reevaluate the need for continued management. For those on bisphosphonates, reassess the fracture risk in about 3 to 5 years, 3 if on IV bisphosphonates, 5 years if on oral bisphosphonates, and consider a drug holiday if the fracture risk is low to moderate, but continue if the fracture risk is still high. Denosumab should not be stopped abruptly due to increased risk of fracture upon discontinuation. If denosumab should be discontinued for any reason, then it should be followed with an antiresorptive therapy. For those on anabolic agents such as abaloparatide and teriparatide, treatment is continued for about 2 years and then followed with an antiresorptive therapy. For those on romosozumab, treatment is continued for 1 year and followed with an antiresorptive therapy. Regardless of therapeutic intervention decided on, lifestyle interventions have to always be emphasized. Those include a daily intake of vitamin D of around 800 to 1,000 international units a day, as well as calcium, 1,200 milligrams of elemental calcium a day, ideally through food. For those who are unable to reach those goals through food alone, then we supplement with calcium carbonate or calcium citrate to be taken with food.